So like hemoglobin is like the Velcro that the oxygen molecule is stuck to, and the red blood cell is a Velcro covered car.
It's like the inner tube
traveling
of it. Yeah, it's
through
like
the bloodstream.
basically.
Well, and that's metaphor fell apart quick. This is Generation Health. Each week we bring you the latest in news, cutting-edge research, and time-tested best practices helping you live longer, better. Sitting across from me, as always, Mr. Dante DiMatteo, registered pharmacist, certified strength and conditioning specialist. How are you, sir?
Doing all right, Tyler. How are you?
I'm good. I'm fantastic. My name is Tyler Andrews, and on third mic, we've got Josiah Schweinberg hanging out back there making us look good. How you doing?
Schweinberg.
Doing well. Privileged to be here.
That's right. Don't you forget it.
I won't.
We're going to talk about a bunch of stuff today. We're going to do a deep dive on anemia, particularly iron-deficient anemia. We got listener questions about that. We're going to talk about iron and iron supplements. Let's keep people up to date on what is going on in the world of pharmaceuticals. A little couple quick hits of news. The latest here, we've got postpartum depression affects about 500,000 women in the US every year. Some estimates say it's as high as, I think, 18% of all women who give birth, obviously, deal with postpartum depression, which makes it particularly exciting that the FDA has approved the first pill for postpartum depression. Zurzuvae has shown in 2 double-blind randomized placebo-controlled trials to work quickly, beginning to ease depression symptoms in as little as 3 days, which is much faster than traditional antidepressant medications. Particularly exciting about this and the fact that it's a pill is that this can help reduce the stigma of postpartum depression, which will encourage more women to seek the treatment that they could actually use instead of trying to tough it out on their own because they don't want to deal with that. So this is very, very exciting. In other news, a Louisiana woman named Jacqueline Bjorklund is suing the manufacturers of Ozempic and Mounjaro, those being Novo Nordisk and Eli Lilly, respectively. The lawsuit alleges the manufacturers downplayed the severity of the gastrointestinal events caused by the drugs, those including gastroparesis and gastroenteritis. Paresis being when the stomach doesn't contract, right? It's a paralyzed paresis.
Yeah,
and enteritis is swelling.
Yeah, enteritis can just be any sort of inflammation.
Okay.
Infection.
All right.
You know, that sort of thing.
For those that don't remember, Ozempic and Mounjaro are developed to manage blood sugar levels in adults with type 2 diabetes, but have become incredibly popular recently for their off-label uses as weight loss drugs, thanks in part to seemingly miraculous results and celebrity endorsements. Don't get your drug advice from celebrities. Reuters is also reporting for Novo Nordisk that Novo Nordisk has said a large study has shown its highly effective obesity drug, Wegovy, also had a clear cardiovascular benefit, boosting the Danish drug maker's hopes of moving beyond Wegovy's image as a lifestyle drug. The late-stage trial showed that patients on Wegovy had a 20% lower incidence of heart attack, stroke, or death from heart disease compared to those on a placebo. Those are 3 big headlines, those last 2 being related. Tell me your thoughts, Dante.
It is something that I do find interesting because we see the GI side effects in practice all the time.
Yep.
At this point, most people know somebody who is using one of these medications.
Yep.
For good reason. They are working very well. There's obviously tons of shortages going on. So it's just this, we talk about it every other show, it feels like, to some level. We'll look back on this in 10 years and, 20 years. Be like, wow, do you remember the boom of the GLPs? And all that?
How often does a pharmaceutical come out that everybody knows about?
Yeah, exactly. It is weird. It's the first time I've kind of reflected on it in that way.
I mean,
just how big it's
honestly,
been.
The last time I can think about this was like Viagra was the last one that came out, and everybody knew the name of a drug, which that's kind of a weird thing.
Yeah. In the package inserts of these medications, what's the person doing the suing?
The plaintiff?
The plaintiff,
I believe.
There is no specific warning for gastroparesis. I just assumed that there was. And so I went back and just for the heck of it, looked at what comes with the actual medication itself. You can reference these online as well. And it explicitly leaves that out. So given that, they definitely have a case. The thing that I find additionally interesting is that gastroparesis, the diagnosis is a little tricky. So just because you have the symptoms of delayed gastric emptying, let's say, all of the stuff associated with that, there's like the early fullness, bloating, nausea, the weight loss, heartburn. So all of that can occur, but does not mean that there's a specific definition for gastroparesis. So there's additional steps that need done clinically to additional testing basically to confirm this diagnosis. So in this case, I assume she had the diagnosis of gastroparesis, but basically what they do is there's a test to measure how fast the stomach is emptying. And so it has to fall in this specific criteria for it to be considered gastroparesis explicitly. So I just felt basically all of that's to say, this seems like a very gray area.
Yeah.
It's not like she, God forbid, walked away with a, pancreatic tumor or something that was just like, wow, like this occurred. Not to say that everything associated with gastroparesis isn't devastating.
Right.
It's just, it is something that's seems like it sits on more of a spectrum.
Well, I seem to remember Joey talking about describing this medication and saying something to the effect of like, that's functionally what it's supposed to do.
Yeah.
Is delay the emptying of the stomach. So it's almost like, well, yeah, it causes gastroparesis. That's literally what it's supposed to do. It's like, I don't know, getting an epidural and being shocked that your legs are numb. Like, that's the point.
Yeah.
But that isn't to say that that's not a big deal, that can have incredible consequences. And I think what's interesting is a lot of people, any trials or anything that they do, they have all the side effects. They see a lot of this stuff in the trials, but once it hits the mass market and you go from 1,000 people to 10,000 people or 100,000 people, all of a sudden, 2 people experiencing something, multiply that times 100, that's a lot more people experiencing that issue. It becomes a much bigger deal than what it seems like initially. So what's the punchline? I mean, I know we're not making recommendations for people to or not to take drugs, but it seems to me that these are both serious medications, all 3 serious medications, and you need to be aware of what you're doing when you do this.
Yeah.
Right?
Yeah, because again, it is a fine line. There's a spectrum. It's pretty gray when this becomes, again, the side effects that you can maybe expect.
Right.
Or a sign that the medication's working. It can quickly become blurred into, well, I am feeling more full. I'm a little more bloated, but this is supposed to be normal. But then all of a sudden, I feel like you start to shift into acid reflux that you never had before. You shift into more consistent nausea.
Yeah.
Like dull, sharp, aching pain. That's, it's a kind of a stepwise way to get to this a little more seriously. So as soon as you start to notice that, you obviously bring it up to your pharmacist, but at that point you go to the doctor because maybe you escalated the dose a little too quickly. Maybe they can pull you back down.
Up, right?
Yeah. Or maybe this just, again, it's like anything. We're so, we're talking about so much of the good with this medication. There's certainly going to be people who just flat out don't tolerate it. There's a lot of why some of the insurances aren't picking this up on their formulary is because there is a generally high discontinuation rate. So adherence is tough because some people just get pushed to this level of side effect and there's fear of this progressing into a gastroparesis, or, you can't be nauseous all the time and you can't have all this acid reflux. And so, you quit taking it. So it's, again, the punchline is just that it's tough to monitor these side effects. Some of them, it is worthwhile to see through. Yeah. But again, it blurs quickly into some pretty unfortunate stuff.
Yeah. And I just, real quickly, we don't have to belabor the point, but would I be correct in thinking that if you are not the type 2 diabetic side of things, but for folks that are taking these for weight loss, that this really is supposed to be, generally speaking, almost a last straw before something like gastro
Like
bypass or something like it's not for if you need to lose 20 pounds, it's for people who are dealing with morbid obesity and things like that. Is that correct?
For the most part, and like a lot of the, indication criteria is a little, I'd probably have to reference some of that stuff specifically, but
Sure.
But BMI over 30, BMI over 27, there's different cut points to look at. But but to your point, it's hard to classify like how many attempts has somebody made to lose weight, how many diets, how many things have they done, how many other medications, it's tough. I don't know. I think that brings about more of like a philosophical question.
Sure.
That there's like, who's to say who is a good candidate versus a bad candidate?
Right.
Do you really need to have a cardiovascular risk factor? Do you really need to have these elevations in blood sugar to qualify? Does it really need to be a last resort? It's tough. I don't know. I guess I don't have I have feelings, but I don't know what the answer is there.
You have to weigh the risks versus the reward.
Mm-hmm.
It's a trade-off, and you got to decide which is whether or not it's worth it for you in your situation.
Exactly. And it's a long-term commitment because upon discontinuation, just like kind of the yo-yo dieting thing, there's a good chance that you regain some of the weight that you lost.
Yeah.
So it's a great thing. It's not perfect, but I'm still in the camp that this is going to help a lot of people.
Right.
It's going to continue to help a lot of people.
Very cool.
But that doesn't mean there's also people not misusing it. And,
yep.
This isn't for your summer vacation in 6 months and you
that
just want to drop 8 pounds. It's not, that would be nice, but it's just,
I think that's part of the point that Novo Nordisk is hoping for is that with Wegovy is that it's not a lifestyle medication, air quotes, of going, hey, just be a little slimmer, take this drug. Like this is for a medical issue.
Right.
This is a misuse of this drug completely for weight loss. I mean, it's intended for diabetes.
Well, originally, but the Ozempic and I'm going to speak ultra crepidarianistically now.
Wow. That is a word.
As one of my favorite words. It means speaking outside of your realm of expertise. But Ozempic and Mounjaro were designed for type 2 diabetics who were insulin resistant, had metabolic syndrome issues, but it had this fun side effect of them losing weight. Wegovy is functionally the same thing as Ozempic, correct?
It's the same active ingredient.
And just slight variations
in the dose.
But it does the same thing.
Just
and
basically rebranded.
Yeah.
So it gained the extra FDA approval. That stuff is another complicated. They had to do that basically, but it's just a reflection of the system being a little tough.
Yeah.
But that's how, those serendipitous findings like that, that's medicine is riddled with that sort of thing.
Right.
Whoever developed this, they knew eventually this was going to help weight loss at some point, but it takes a while. It takes a while to figure that out. There were a lot of drugs in this class that weren't great. There were more side effects early on, and now you're getting to I think towards the end with some semaglutide and Mounjaro and those sorts of meds. Those are the I don't foresee like 50 more of these being made.
New variations that are
like we're towards
radically
the end of
different.
That. And sorry, I don't know if that was all of Josiah's point, but
yeah, no, I was just for someone who knows little about the drug, to be using a drug for weight loss seems like a misuse, like you guys were just clarifying earlier. So I just don't know how that's even possible for people to get it when it's meant for something else. I guess that's the abuse of.
No, doctors prescribe things off label all the time if they know that it's got a side effect, air quotes side effect, a function that happens on the side. There's antidepressants that get used for ADHD. There are all kinds of things like that happen all the time. And it's, we should probably cover that. Like, what is off-label use? Is it okay?
Yeah.
We'll talk about that sometime soon.
Yeah. But Josiah, that's a good question. And what we've kind of talked about, I think in previous Generation Health episodes. It was that the obesogenic environment, just the current state of obesity as a disease state, more shifting the lens more towards that. There needed to be something big like an Ozempic, Mounjaro to step in, because a lot of what we're doing on a large scale simply wasn't working.
Right.
And so it was just a matter of time for those meds to get the additional approval. But how that plays out practically is where we are now, just in retail pharmacy, really, is that there's a lot of people who could use this that are now not getting approved because some insurances just won't recognize it because the indication's not there, because this is a $1,000 drug. And so the cost sort of gets in the way of this. The water is muddied for people. And it's like all of a sudden it flipped. And now it's like all of a sudden, before you could get your doctor to write for it off label and it could slide through on the insurance end. Now insurances are like, these are big audit flags.
Wow.
And so if you don't have the specific indication, they're, trying to cramp down on prescribers, and so with the drug shortages now, people can't even get the stuff.
Even if they could
kind
get
of
it
a mess.
prescribed.
Yeah, it's it's not all because of off-label use, but it's a mess, you know, and it takes time for a drug to not only get approved for a new indication, but then also for an insurance formulary to recognize that indication and start paying for that for people. And so, yeah, I still don't know if that's exactly what you were after.
Yeah.
But that's I think practically how that plays out.
All right. Debbie on Facebook wanted to know, she said, I have iron-deficient anemia. My doctor found it after I complained about severe fatigue, cold, etc. He sent me to a hematologist for labs and confirmed the diagnosis. Both doctors suggested iron infusions. I just recently had my first, but I'm told it will take some time to see the benefits from it, and I may need a second infusion. A friend recommended Spirulina as a supplement to help. I had never heard of it before, so I thought I'd check with you. Is this something I should be taking to help with anemia and fatigue? So, what the heck is anemia?
Yeah, since we haven't really touched on anemia much yet, it feels like, for discussion's sake, maybe we just run through some of the background as a whole before jumping into iron deficiency anemia. So,
because I learned there's a difference.
There's a difference, yes. So anemia is an interesting topic. I remember not liking it too much in school when we had to study for it for a test, because there are many layers to the diagnosis, to understanding the causes, and I don't know, just like anything, the more you learn about it, the more that you realize how specialized a topic it sort of is.
Yeah.
So with that said, in a clinical context, anemia is really referring to the blood's inability to properly carry oxygen throughout the body. Since the oxygen is not making it to other cells throughout the body, those cells will then struggle to make energy effectively and efficiency. So yes, when you look at the word anemia, it's like the loss of blood or lack of blood, or you can interpret that as a decrease in red blood cells, let's say.
Okay.
I still think it makes sense to in a more clinical sense say, okay, what's really happening
specifically
with this? Yes. So how do you know then if you're anemic? To review, there's usually clinical symptoms that would warrant for future investigation. There are 3 categories of causes that would further guide how anemia would be treated. There are laboratory markers, as I said, that will help explain what's actually happening and help to further flesh out what that cause is. And then clinically, we alluded to some of those symptoms, but it's important to, I think, rehash those. Most commonly, you'll see fatigue. Someone's complaining of being lethargic. That's usually the top of the list. Pallor, so a reduction in skin color and tone.
Okay.
Cold hands, basically, again, just reflective of blood not circulating to the periphery very well.
Right.
shortness of breath, reduced capacity to exercise, increased heart rate, headache, edema, and even jaundice can occur.
Wow.
So again, a lot of these are the most common symptoms. They're not all always present. It'll depend on what kind of anemia is going on.
Sure.
But in general, those ones are seen quite commonly.
What are the kinds of anemia, real quick? Just so we can at least mention them.
Iron deficiency anemia is the most common
Okay.
type, I would say, worldwide, statistically speaking. But there are normocytic anemias, microcytic anemia, macrocytic, and that's referring to the size changes of the red blood cell.
Okay.
And so I think I don't want to jump ahead there quite yet.
Sure.
But yeah, that's helps with classification. And
Yeah.
so before we even get there are, again, these three potential broad categories of causes. So blood loss is kind of the most intuitive one.
Okay.
Again, if we're talking about the reduced capacity of red blood cells to carry oxygen, what a better way to diminish that than to literally not
Lose some red blood
lose
cells.
blood, you know?
Yeah.
So there's maybe an acute trauma, or there's a GI bleed that's more serious. Again, these more acute situations, even menstruation is a
Okay.
very
Makes
common
sense.
place where, you see women who are pregnant, women who are still having regular periods that are often classified as anemic. So blood loss is number one. There's also the decrease in production of red blood cells. That's a huge one. So again, you can tie all of this back to what was our initial definition of anemia. Third would be increase in the destruction of red blood cells.
Okay.
So examples of those would be autoimmune diseases, sickle cell disease, malaria even is an infection where ultimately there are, I believe, like parasites that
Destroy the
attack
red cells.
Yeah.
Red blood cells. Wow.
Yeah.
So that's not what Debbie is dealing with.
Right. And I feel bad. I think we'll obviously get to Debbie's.
We're coming back, Debbie.
We're coming back to the question. But again, I don't know. I think it's a good review for us. It's a good review of people to see, how maybe your provider got to that diagnosis. And I think what'll help even more is if we even talk about now some of those specific lab markers on a CBC that might explain, might explain the symptoms, explain the root cause.
Yeah.
So firstly, on your CBC, you might see a
CBC being complete blood count.
Mm-hmm.
Okay.
So that has a plethora of things, but we'll highlight the pertinent ones here.
Okay.
You're typically going to see a reduction in red blood cell count, and I'm purposely being redundant there because that's kind of the foundation. Again, it makes intuitive sense. The less total number of red blood cells, the less amount of oxygen there is being moved around. You will then also see a decrease in hemoglobin.
Okay.
And so hemoglobin molecules, those are basically all over and make up the red blood cell. And that's truly what gives the red blood cells the oxygen carrying capabilities.
Okay.
So that's the big part. Essentially the red blood cells are just like these vessels that carry around hemoglobin, which carry around oxygen. And that's their primary function.
So like hemoglobin is like the Velcro that the oxygen molecule is stuck to, and the
Yes.
red blood cell is a Velcro covered
It's like
car
the inner tube of
traveling
it. Yeah, it's
through
like
the bloodstream.
basically.
Boy,
And
that
that's
metaphor fell apart quick.
we'll give it to you.
Thank you.
And then looking at the makeup of that just a little more granularly, heme molecules with iron attached. So basically heme molecules with iron attached, that's what makes up the hemoglobin. And that's where the oxygen molecules ultimately attach.
Okay.
So just to, expand upon your example there, that's all those iron components are also then very important.
Got it.
Which will, tie us into the iron deficiency a bit later. The other parts of the CBC that we'll look at, so that will help further explain the underlying cause, would be looking at reticulocytes.
Okay.
And so these are the red blood cells that are immature or not fully developed. So when red blood cells are being made from the bone marrow, reticulocytes are like a step along the process that you can actually measure. And so that'll be reflected on a CBC as a percentage. And so it's important to keep that in mind, because if you are looking at somebody who had maybe an acute blood loss, there was a trauma, God forbid, the reticulocytes, because that's just looking at a step along the production in these red blood cells, they're typically not affected by blood loss. The reticulocytes are typically low if there's just a decrease in the production. So we go back to these causes.
Got it.
All right. So that's one. The mean corpuscular volume, or MCV.
Okay.
Sure, we've seen that before. You've seen that before. That refers to the red blood cell size or volume.
Okay.
And so I mentioned macro, micro, normocytic anemias, basically whether the cells are small, large, or normal. That matters in terms of, again, determining this cause. Typically, when looking at changes in the MCV, that's, again, more reflective of an issue with production of red blood cells. It's less affected by blood loss. You know, if you have a situation where you're bleeding a lot, there's generally no reason that those cells would have increased in size or decreased in size.
Yeah.
Anemia of chronic kidney disease, that's a very common disease state with aging. That typically leaves MCV unaffected, because it's the anemia of chronic kidney disease, and not to go too far into this, that's more of an issue with the hormone erythropoietin, which stimulates your bone marrow to produce red blood cells.
Okay.
And so if it's an issue with that hormone, generally you're just producing less. That doesn't mean that they changed in size.
The ones that are being produced are fine. It's just there's just not enough of them.
Yes, and I apologize for this being a bit rudimentary as I'm going through it. But again, it's just, I don't know, it helps, because how many of us have to get CBCs done for a multitude of reasons, and it helps you maybe ask, some more of the right questions.
Yeah.
So there's only one or two more pieces here that I want to mention before we get into iron deficiency specifically.
Okay.
So hematocrit, or HCT, is the percentage of red blood cells to total blood. And so you will definitely see this drop in the case of, blood loss, whether that's a GI bleed or, the things that we mentioned. Finally, when when your provider has a reason to suspect anemia, they will even look at a sample of blood through a microscope, basically a blood smear of some sort. That will kind of confirm how the size of the red blood cells have changed or may not have changed.
Sure.
This is where we see those classifications that I mentioned earlier: normocytic, or normal sized red blood cells, microcytic, red blood cells with a reduced size, and then macrocytic, red blood cells that have increased in size.
Sure.
So we're not going to go through every single one of those. Iron deficiency now, the tie-in, and so we'll get back to Debbie's question here.
Yeah.
That's one of the primary causes with microcytic anemia. Again, it's the most common cause of anemia worldwide. And why does this cause microcytic anemia? Why is this reflective of a microcytic anemia? It's because iron and other nutrients such as B12 and folic acid, those need to be present when red blood cells are being made from the bone marrow. So again, this goes all back to that, to that production process. When those nutrients are missing or deficient in some way, eventually not enough hemoglobin is going to make it onto those red blood cells. Not enough because of, in this case, we'll say not enough iron. There's no real way that the normal amount of oxygen can bind to the iron and oxygen.
It literally just can't carry enough for it to do its job properly.
Yep. And so typically what happens, the less hemoglobin that makes it onto the red blood cells typically means that the size of the red blood cell is going to be diminished.
Got it.
Because that's primarily what they're made up of. And wow.
Yeah, that
was
deep.
Cool. Yeah, you get my point there.
Yeah.
The less hemoglobin that makes it onto the red blood cell, the larger chance there is that the red blood cell is smaller in size. Now, that's not every case,
right?
But that is that's a general rule of thumb.
Right.
So also, when looking at iron deficiency anemia, It's also critical to look at serum ferritin.
Okay. What's that?
That is reflective of the iron stores.
Just within the blood?
Yes.
Okay.
So that, in addition to looking at hemoglobin, in addition to looking at red blood cell count, in addition to looking at all the other things we mentioned, when you're getting to the point that you might suspect an iron deficiency anemia, you need a more iron specific metric, as in serum ferritin, to kind of confirm that you're going to be treating the right thing.
Got it.
All right. So again, there's normocytic, there's macrocytic. Those involve B12, folic acid, more things that I think maybe we come back to eventually.
Yeah.
But how do you become iron deficient in the first place? Maybe there's a decrease in dietary intake. So you're not eating a ton of red meats. Vegans, vegetarians have maybe a predisposition to IDA. There are cases where someone has an increased iron demand.
Okay.
And that's maybe a growing and developing person. That's maybe a pregnant individual. Also, reduced absorption. That can be a cause. Maybe you had some GI surgery, or there's GI issues going on affecting how you're normally taking in nutrients and assimilating them from
things like
from
SIBO
food.
or other
Like celiac disease.
Yeah, there are tons of nutritional related, ailments that can't contribute to that.
reduce the
The
absorption
capacity.
of iron. Okay.
And then again, blood loss is another just classic example of how you
Right.
could end up even with iron deficiency anemia.
There's actually one of the risk factors for low iron anemia is frequent blood donors.
No kidding.
People who routinely donate blood may have an increased risk of iron deficiency anemia, since blood donation can deplete iron stores.
They do check my blood every time I give.
Yeah, so maybe you have a high hematocrit.
For I have had too much iron one time, but I had just finished eating a steak about 20 minutes before I showed up. And they were like, wow, your iron levels are off the charts. I was like,
Too much iron pumping.
yeah. All right. Debbie needs help.
Yeah.
She's asking about spirulina.
Uh-huh.
What do we got?
Yeah, I know she also mentioned iron infusions.
Yes,
And
she's getting, she
yeah.
got one. She may need a second.
And so for some people, just given that iron's available over the counter, we sell an iron product, why the heck would I get an iron infusion? So again, a lot of that will come back to what's the cause, how serious, have you tried other forms of iron replacement? Those are all factors.
Okay.
Early, like iron dextran, I believe it's still used, but that's an example of IV iron or parenteral iron
Okay.
that had a higher risk for anaphylaxis and some of these other adverse events that are, if you Google this, that you'll find hypotension, diarrhea, cramps, infusion-related reactions, which sometimes people would have to even try a test dose, like a very small dose first
Wow.
to see how they respond. A lot of things that deterred widespread use, unless you're in a situation where you're inpatient, you need to replace this iron immediately, or again, somebody just cannot absorb it orally, so they end up in that situation. I don't know what Debbie's reasoning is in particular, but I can understand now why it's appealing, because there are newer forms that are even shorter infusion time, less reactions. You don't have to get as many infusions.
Right.
There are some of them you can replace all the iron that you need in one or two infusions, is from what I can tell just from
That sounds
basic
like
reading.
what
So,
she's dealing with. Yeah.
yeah, so that's appealing.
Yeah.
If you are okay with needles and you don't mind taking some extra time to go do it, and you're a candidate for that, and you have no history of, maybe reactions to something similar,
Yeah.
then more power to you. It's a surefire way
Yeah.
to replete your iron stores. That's the goal of treatment.
And
So,
how long would that last? Like, is it something you would have to do every 6 months, every month, every 6 years? Or is that a one and done?
I want to say that you won't know until you have follow-up blood work done. Because
Makes
then that's
sense.
going to warrant further investigation. If you keep
Right.
getting these iron infusions and in 6 months you end up exactly where you were every time, maybe that's not like the most evidence-based answer, but
Right.
But I do know that's why that there's follow-up testing.
Sure.
Because you
Yeah,
know?
you got to make sure that whatever
where
caused
do
the
you
problem
stand?
to begin with is
Yes.
taken care of. Makes
Because
sense.
then you don't want to go the other way either. You don't
Yeah.
want to get into this situation where you have an excess of iron, God
Yeah.
forbid. So that is the spiel on iron infusions. Now, spirulina,
Yeah.
historically used by the Aztecs as a food source.
It's an algae, right?
It is blue-green algae, a cyanobacterium. Yes. But now primarily found in capsules, tablets, dry powders, smoothie shops.
Yeah.
It's hot.
It is.
It's a hot product.
And there's a lot fewer Aztecs around.
There are fewer Aztecs. Yeah, apparently they harvested it from Lake Texcoco in Mexico. They sold it as cakes, and again, they consumed it as just a basic food product. But then after like the 1600s, I guess, they were unable to see anyone using it for those purposes because I guess the lakes were drained.
Yeah.
And so the blue-green algae was obsolete.
Yep.
And now we have it
But now it's back.
It's back. It's back. So why do people care about this? It's touted as a superfood. In higher amounts, there are various vitamins and minerals. There's beta carotene. There's proposed anti-cancer effects. It has a role in allergies. It has a role in, you can add some protein supplementation to your diet with this stuff.
Wow.
So there's all these things. But the role in actually treating or preventing any sort of deficiency or illness, there's pretty much no evidence to say that this is viable in and of itself.
Okay.
So if she wants to add this to her diet, she really doesn't have to worry about this adding a overload of iron, even with her infusions, because you would have to consume 100 grams of spirulina to even get 28 milligrams of elemental iron.
Wow.
Which is very low.
Yeah.
That's a very low amount. And 100 grams of spirulina is a lot. Most of the powders that you can buy, they have 3 gram, 5 gram scoops.
Okay.
So you'd have to eat like 25 times that for it to even matter from an iron perspective.
So in a literal answer to her question, as far as the iron is concerned, it's probably not going to move the needle at all.
No.
Okay.
No, it's safe, well tolerated. Get it from a good place. We might have it in a product or two. I don't think that we do in any sort of meaningful way. Maybe
Not
in
as
like
a focused
greens
product.
Yeah, just maybe you could do the greens.
Yeah.
I don't know. That's the point. You might see this in a greens product, and that's why you're doing it, not because you think that you're going to get some enhanced iron absorption or iron supply. Better suggestions,
yes,
would be if theoretically they were anti-infusions, wanted to start with an oral product. There are ferrous sulfate, ferrous gluconate, and then our Anemia essentials, which is a different form of iron. It's an ionized form, which the thought is that it's a little more well tolerated than the first two that I mentioned. So again, back to what we said at the outset, we see that people stop taking the iron because they had the negative side effects, which pushes them towards infusions.
Right.
If you try something like the Anemia essentials, we've carried it for a long time. It seems to be generally well tolerated. Now, how many of those people would have been fine on ferrous sulfate, ferrous gluconate? I don't know.
Yeah.
A lot of people came from ferrous sulfate to the Anemia essentials. A lot of people just went straight to the Anemia essentials. So it's hard to like parse out the signal from the noise there, but it's a quality product for sure in this setting. But if you're already doing infusions, I would not add this in any meaningful amount. The Anemia Essential specifically carries 25 milligrams of elemental iron per tablet. The treatment guidelines suggest 120 milligrams of elemental iron per day for 3 months.
Wow.
So
yeah, she'd have to eat a lot of spirulina to get anywhere close to that.
Right. So you're not going to be able to get a perfect conversion from Anemia Essentials into that recommended amount.
Sure.
So you would probably have to do 2 to 2.5 twice a day to hit that number. And then at the 3 month mark, you say, okay, where are my numbers?
Right.
How has the CBC changed?
Yeah.
How are my symptoms? And then you decide maybe I don't need to take it anymore. Maybe you drop down to 1 or 2.
Yeah.
Because again, this is not something we're just going to recommend somebody to overload
Yeah.
themselves with iron.
There is a downside if
Yeah.
you go too far.
Mhm.
Fair enough.
Some other clinical pearls, as they would call it
Oh,
in school, to keep in mind.
okay.
Iron products are best absorbed on an empty stomach,
Okay.
but you have to weigh this with the potential for the GI upset. So we suggest people to take it with some food if they can't tolerate it. But the caveat is absorption can be decreased by 40% if you're taking it with food.
Wow.
So we're talking about you're talking about 325 milligrams of ferrous sulfate that you see over the counter. Plus, there's only 65 milligrams of usable elemental iron within that. Plus, if you're taking it with your breakfast, cut off 40%.
Yeah.
So there's a chance that all of those factors matter.
Right.
But the point is, you want to be taking it.
Yeah.
You just want to make sure you're taking it. The recommendation practically would be 2 hours before or 2 hours after taking a medication or food, basically, because there are also many medications that can decrease the absorption of iron supplements. So PPIs, antacids, H2 blockers like famotidine. So all those things can play a role. Also, vitamin C can help increase the absorption of non-heme iron. So that's why vitamin C is often found in products like Anemia Essentials.
Makes
can
sense.
boost the absorption, ever so slightly. And then from a lifestyle dietary perspective, beyond what she's doing with her infusions, again, that's something still that's not really going to be enough to move the needle.
Right.
But it's worth mentioning foods rich in heme iron are things like red meat and livers. Foods rich in non-heme iron would be things like fortified cereals, egg yolk, green leafy vegetables. And then again, you can increase the absorption of the non-heme form by co-administration with vitamin C.
Makes sense.
So that's citrus fruits, peppers, strawberries, all those kind of things. Plus, maybe you have a separate vitamin C supplement, or you're taking something like Anemia Essentials, which has a little bit in it.
Cool. Okay. All right. Well, that carries us nicely, almost like it's planned, into Ilyana's email. She emailed us at questions@askjoedimatteo.com. You can email us there too. Please do. She said, I used to listen to the Ask Joe DiMatteo show. I missed the show, and I was glad I found your website and the YouTube Generation Health episodes. Anyways, I'm looking for a second opinion, and maybe you all can help advise me. I recently got my lab results back, and the ferritin level is at an 8. My doctor is a bit shocked because my iron levels, hemoglobin, and the saturation percentage of iron transfer are all in the normal range. He still prescribed me 325 milligrams of ferrous sulfate twice a day for 6 months with a recheck of labs at 3 months. All of this is making so much more sense after that education. Thank you. Okay, back to the email. I haven't taken the prescription because I'd rather try a holistic approach, and I actually would rather take liquid forms of pills. Yes, I'm one of those people who can't swallow pills, and I crush them instead, even though I'm probably not supposed to. I talked to my friend who is a registered dietitian and nutritionist. We came up with a meal plan to help increase my iron, which I've been following for the past 3 weeks now. My friend suggested that I take the ferrous sulfate as prescribed in addition to following an iron-rich diet. What do you guys think? Is there a functional, holistic approach to increasing my ferritin levels? Thanks for your time and addressing my concern. I truly appreciate it. All the best, and God bless, Ilyana. Thanks, Ilyana.
Thank you.
All right.
We got all the background out of the way.
Yeah.
So we can jump right to this question.
Yes.
I would echo her friend, who is an RD and nutritionist. And yes, continue to do those
Take
things.
it as prescribed.
Definitely.
Yeah.
And so why? And I think the why is how we can approach answering this question. This is not iron deficiency anemia. This is iron deficiency.
Okay.
Oftentimes what can happen from my understanding is that those things that can occur. You don't have this overt, maybe she was having symptoms, right? but
her other numbers were all fine.
all of her, yes, the ones that we talked about, maybe her red blood cell count was okay. Her hemoglobin wasn't anything of concern.
Right.
So no technical clinical anemia is present, but that doesn't mean that this couldn't progress into an iron deficiency anemia versus a iron deficiency.
Got it.
So you kind of see what happens by following the recommendation. I think it makes sense, but I like this question because it highlights the complicated nature of what a clinician would have to do in this case.
Right.
Because you can make the argument, she's kind of like, well, what the heck? I'm not anemic technically, is kind of what I hear her saying.
Yeah.
Why do I need to do this? My doctor's surprised at the levels that are being shown here.
Yeah.
And so that also speaks to kind of the individual nature of all of these sort of case reports or case studies, really is what they are.
Yeah.
So she's definitely, again, got to continue on trying to replenish those stores. Now, again, we did mention ferritin. And so again, that's something that pops up regularly in these sorts of evaluations. It's the most sensitive and specific biomarker when assessing iron deficiency.
Makes sense.
So clearly this is indicating some issue with iron stores. And to the flip side, ferritin is actually an acute phase reactant. And so what that means is in the presence of an infection or malignancy or high inflammatory setting, the ferritin is upregulated. So in her case, if she did have some sort of underlying malignancy, infection, inflammatory condition, this ferritin would be elevated. And so in her case, doesn't seem like that's something that they're going to have to be concerned about. So they just got to treat this, kind of see what happens, see if whatever symptoms she might have, see if they're resolving, or, ideally you prevent any sort of additional symptoms from occurring.
Yeah.
Now, it would help based on what we talked about prior. I would be curious for the completeness sake of this case study to see the hemoglobin, to see the MCV, to look at these things to say, hey, we talked about what these mean. We talked about why we look at them. Now, what do Ileana say?
Yeah.
It would be cool. But again, we're assuming for the most part that those are all normal.
Yeah.
Ultimately, she probably doesn't need any additional testing from there. I mean,
other than at the 3-month mark.
Yeah.
If she's taking the iron supplement.
Yeah. Yeah. And then she also mentioned that she prefers the liquid form.
Liquids over pills.
Yeah. Because we don't have the specifics of her ferrous sulfate product.
Got it.
We would say, don't crush that one. You can look for a liquid form. You can look for a chewable.
Those exist.
Those exist. So in the event that this is enteric coated, or there's something about it or maybe it's extended release, something that would change the nature of the product, maybe irritate your stomach, something weird that we want to avoid, just make sure, there's a billion ferrous sulfate products. We just want to make sure this is one that you can kind of mess with. So
the answer is
there's options.
There are options that you can crush and you don't have to. There are liquid options, but not knowing which one she has, we can't just say, yeah, go for it.
Yeah.
But she should talk to her pharmacist and ask for one of those options.
Definitely.
Makes sense.
Definitely.
Makes sense. Are we missing anything else in that question there? She said she can't swallow pills.
Holistic approach to increasing my ferritin level.
Right.
Those would be diet.
Yeah. The same points that we echoed a little bit before that. Continue to search for foods rich in iron. Maybe they won't be enough to move the needle, but if they were foods she wasn't regularly consuming,
sure,
then potentially that can help. And there's, again, things like certain red meat, liver, egg yolks, green leafy vegetables, strawberries, peppers, citrus fruit.
Yep.
Those are part of a health promoting diet anyway.
It's all things you should be eating.
Someone used to say, eat the colors of the rainbow.
That's right. That's right. What color is liver? Purple? Does that count?
The Liver King?
No.
Oh, man.
No.
Oh, man.
All right. That tells me it's time for us to wrap this up. All the products we mentioned are available on our website, askjoedimatteo.com. That site is also where you can sign up for our mailing list, find past episodes of this show, Generation Health, or the show that started all of this, Ask Joe DiMatteo. That website is askjoedimatteo.com, askjoedimatteo.com. If you have any questions, email us, questions@askjoedimatteo.com. Show notes, anything we talked about, the articles from the beginning, those are all going to be available down in the show notes section of this, wherever you're listening or watching. And if you learned something from this episode, or you know someone else that could use this information, please share it with them. If you're listening on Apple Podcasts, give us a 5-star rating and write a review. We love those. They help us so much, and they help other people find this information who are looking for it. If you're watching on YouTube or Rumble, thumbs up would be great. Subscribe, leave a comment down below. We love answering all of those. We try to respond to every single one, so please do it. It helps us out, and it helps with the algorithm. Big thanks, as always, to Josiah Schweinberg, running cameras,
right,
riding that third. Okay, we're going to take his mic away. Michael Deppish, our editor. Joyce Gibb, our nurse practitioner who handles private consultations. Diane Silverman, who handles product. We've got Terry, who does scheduling. Cecilia does distribution. That's Dante DiMatteo over there. I'm Tyler Andrews, and that is it for us this week. Thanks so much, guys. See you next time.